All right, good afternoon, everyone, and welcome to the Public Health Science Echo, where the public has the opportunity to ask science-based questions for our public health team. This session is produced and facilitated by UAA's Alaska Echo Project in partnership with the Department of Health and Social Services. My name is Erin, my pronouns are they, them, and I'm with Project Echo. For those joining us on Zoom, questions may be entered in the Q&A feature. For those joining us on Facebook, please add your questions in the comment section and they'll be shared with our panelists. As a reminder, we do expect all participants to keep questions and comments on topic, to be considerate, and to use language that is respectful. So for that, I thank you in advance. If your internet connection does not support audio, you may join us by phone by calling the phone number we've entered in the comment box along with the meeting ID. Closed captioning is available as well. The CC button is on the bottom of your Zoom screen, and thanks so much to our captioner. I'd also like to note that the opinions expressed in this session are those of the speakers and do not necessarily represent those of UAA, DHSS, or any of our ECHO sponsors. Our hub team should all be familiar faces by now, and in an effort to maximize our time together today, we'll go ahead without introductions up top and instead let our hub team members introduce themselves during the session when addressing questions. So without further ado, over to you, Dr. Zink, for today's presentation.
Great, thank you so much. So presentation today is a little bit on the shorter side, so we've got lots of time for your questions. So please feel free to put in that Q&A any questions that you have. Again, we have a diversity of talents and expertise on here, and hearing from you all is really helpful. And so with that, I will go ahead and start to share my slides. So here we are. I don't know, what did we figure out, Erin? This is, I think, our 68th weekly public science echo. So thanks for the team for being here for so many echoes, and for Alaskans continuing to show up as we continue to share information about public science. And a lot of this has been about COVID overall. So with that, here is the national trend in COVID cases. So you can see really in November, there was just this really big surge nationally, and we're starting to see a little bit of a decrease nationally, which has been fantastic to see. But we haven't quite gotten that same trend here in the state of Alaska. So here are our cases here. We had a 13% increase from last week with just over 637 cases per 100,000. The majority of the state is in that red, but we've started to see some regions starting to come down, while some regions are really starting to continue to pick up overall. We had over 1,000 cases today, so 1,068 cases. The team has been working on the back end to try to streamline some of the processing to get those up. Remember, those are the dates that are reported to us, but we always encourage you to look at that onset date because everything is slow in the system right now. Tests are taking a longer time to come back. It takes a longer time for healthcare facilities to report those tests for us, and then for our team to be able to go through them, figure out what their regions are, and get them up. Unfortunately, this is not a perfectly automated process. It takes a lot of hardworking people on the back end working very long hours to get these numbers up and out to you as quickly as possible. And we have just over 94,000 cases that have occurred in Alaska that we are aware of that have kind of been reported back in. And then unfortunately, we are seeing those Alaskans, some of them are getting sicker and some of them are requiring hospitalization. So our hospitals have been and continue to be incredibly stressed. There is not capacity in the hospitals to care for both COVID and non-COVID patients on a regular basis. So our emergency departments remain open. They continue to do amazing work to try to get things as available as possible and to see people who need them. But it is getting stressful in the emergency departments, in the hospitals, in the ICUs, and other places secondary to both COVID and non-COVID. Currently, just over 20% of people in any Alaska hospital right now are secondary to COVID-19. Some of our hospitals have surpassed over 50% of the people in their hospital are secondary to COVID-19. We have 201 Alaskans right now ill enough to require hospitalization, and 34 of them are currently on vents. Many are also using things like BiPAP and high flow oxygen, other kind of support services overall. And you can see the distribution across the system as a whole. This has been really reflected in some of our national data as well. So this is Alaska state data that comes from the CDC tracker. And again, you can see just this pickup of hospitalizations, which has actually been more than what we really experienced in that November surge. A couple of things that I think are happening here. First of all, Delta is different and Delta is deadly. So Delta just moves really quickly from person to person. So when I, as an individual, think about, what disease would I be willing to get or would like to get, and I think about something like Ebola versus something like COVID, COVID for my individual mortality is going to probably be less. And so that would be less threatening. But when I think about the population as a whole, a disease that spreads really quickly from person to person is going to cause overall more deaths. So from a public health standpoint, something like COVID is really challenging. And I think that's what we're seeing right now overall in our hospitalizations. When a lot of people get sick at the same time, it really overwhelms our healthcare system. It overwhelms our hospitals. And then we start to see excess mortality or more people dying from other things such as heart attacks and strokes and car accidents and bear maulings or whatever else happens to be happening in Alaska overall. So it's for these reasons that we all are trying to do our best to try to kind of, again, flatten that curve and keep us underneath our healthcare capacity. That has always been the goal. So it has been one of the sharpest surges of COVID-19 cases amongst the states and one of the sharpest increases in hospitalizations here recently. So again, thank you to our healthcare workers out there who are fighting this on a daily basis. They are here to care for you regardless of your symptoms or why you have been there, but it is becoming challenging and hard in many, many respects. And so just wanted to pause and offer just immense gratitude for the work that they are doing on the front line in so many ways and regions. And people get asked this all the time, well, how much longer is this going to go on? What's the peak? How much more should we expect of this? Again, this really depends on individual Alaskans making individual choices to slow the spread of COVID-19. So it's really up to all of us and what we collectively do together to slow the spread. People not wearing masks or getting vaccinated in one region is resulting in another region not being able to get their heart attack patient to a higher level of care. We are all connected in our ability to access care within the state and our really limited healthcare infrastructure. So the differences you make, getting vaccinated, making sure that you're wearing a mask when you're in indoor spaces, getting tested at the beginning of symptoms, and then letting your own contacts know. Our contact tracing teams continue to be quite strained. You may not get a call from the team if it's been greater than 9 days by the time we get the report that you were positive from the time that your symptoms started your test. You may not get a call just because we're not going to be able to interrupt transmission because so many days have passed at that time. So we're really trying to prioritize calling those who we can have the biggest impact on the pandemic as a whole, using our resources as wisely as possible, knowing that we're not able to contact trace everyone. So continuing to layer up with your prevention, letting your contacts know, and isolating if you're sick. Thanks to the Chamber, they will be announcing the first winner of this Give AK a Shot sweepstakes tomorrow. It's pretty exciting to see that. And then every week for the next, I believe it's 4 weeks, they're doing ongoing drawings for either $49,000 or a $529 plan for people who got vaccinated that week. So really each week, your odds are actually pretty darn good. So get vaccinated to protect your health, your family, and your friends. But if you get vaccinated now, you may have a chance to win with the Alaska Chamber sweepstakes. Here we are with the positivity. We're just over 9.6% of our tests are positive. Again, kind of creeping up above of even what we saw last November. Really encouraging anyone at the beginning of any symptoms to go ahead and get tested. We know that the testing supplies, resources, and times can be long. We continue to work closely with local regions as well as the federal government to try to improve that. And remember that there are testing options that you can purchase, both everything from Amazon to Walgreens, to be able to test yourself as well. So there's a lot of online and self-directed testing options now available, as well as the testing that we have at the airports and that many municipalities have set up in local areas. So continue to try to get that testing out and available as easily as possible. Vaccines are our tool out of this pandemic. So the immunity or protection that you get against a disease really depends on a whole bunch of things, including your own natural immune system and then how well your immune system is able to take down the virus. When you teach your immune system how to take down the virus with the vaccine, you're less likely to be hospitalized, you're less likely to die. And even if you had COVID-19 before, when you get vaccinated, you're less likely to get reinfected. And so it's for all of these reasons, we really continue to encourage people to consider getting vaccinated. We have reached that 62% of our population, which is great to see. It's very slowly continuing to trickle upwards and encourage every Alaskan to highly consider getting vaccinated to minimize these waves, protect each other, and the biggest thing, keeping you out of the hospital from COVID-19. You can see that compared to July, August kind of picked up in vaccinations. It's starting to kind of dip down a little bit there. So this is another opportunity to go ahead and get vaccinated as we move forward. Delta continues to be our predominant variant. As you can see the last reports, we had 2 cases of Mu, 1 of Alpha, and 206 of Delta. So pretty much if you're an Alaskan and you get tested positive for COVID-19, you can assume it was a Delta case, but we continue to do the surveillance to watch for all sorts of different variants overall. And big shout out to the sequencing team. They continue to do a really great job of sequencing a high proportion of our positives, and compared to many other states are kind of leading the pack in their ability to sequence and see what's happening. So thanks to them. This is information we've shared previously. It comes out in our July report. Here's a link, but again, if we look from January through June, you had a 16-fold decrease of hospitalization if you were vaccinated, slightly decreased in July at a 7.5-fold decrease of risk of hospitalization. So while not perfect, it's impressively good at minimizing your chance. And the other thing that we see is those who are in the hospital with COVID-19 who are unvaccinated tend to be much younger than those who are vaccinated. So again, vaccines help to teach your own natural immune system to take down this virus as quickly as possible. This is the breakthrough data that we continue to share on a regular basis. So 81% of all our cases, 88% of our hospitalizations, and 87% of our deaths from January through September 4th are people who were unvaccinated in the state of Alaska. So continue to follow that along. Getting a lot of questions about booster doses. Again, if you're immunocompromised, you're recommended to get a 3-dose series, which is out and available now. And at this time, there is no new recommendations from the ACIP and the FDA regarding an additional booster dose, but we stand ready to provide it if it comes out. It sounds as though there continues to be a lot of conversation in this front, and we will update you when we have more information. Another reason to get tested is if you're high risk and you're over the age of 12, including if you're pregnant. So we're seeing a lot of pregnant women who are missing this opportunity. Monoclonal antibodies is essentially passive immunity, receiving antibodies to help you take down that virus and minimize your chance of getting hospitalized. So feel free to call our state line, this 907-646-3322, and we can help walk through to see if monoclonal antibodies would be right for you and where you can access them. So another reason to get tested. It isn't just like go home and there's nothing to do. There are things to do to help minimize your chance of ending up in the hospital from this disease. And as always, we have a speakers bureau. We want to make sure every Alaskan feels comfortable in the health decisions that they're making for themselves, their family, and their community, and are happy to answer questions about vaccines, about testing, about variants, or whatever you have, and appreciate. It looks like 310 of you showing up right now, and many of you will share this later so that we can make sure that information is shared widely. And as always, we stand by to offer vaccines any and every way that is works for you and your busy schedule, be it coming through the airport, coming to your house, or going to one of the many, many vaccine centers where you can just walk up, or pharmacists to be able to pop in. And you got questions, pop into your local pharmacist, ask them some questions, talk to your healthcare provider. There's a lot more information now than there was, say, like last December and January, and want to make sure that you feel comfortable in getting vaccinated, because when you look at the risk of COVID versus the risk of vaccine, you are much safer if you get vaccinated than if you get COVID without having vaccination first. So with that, thank you. We need you right now. Our hospitals need you. Your healthcare workers need you. We need each other to all very much step in this space and continue to minimize the risk of COVID-19. Thanks.
All right. So what is the best method for combating misinformation? We have a participant who shares some concern about misinformation that they're seeing, even as a healthcare worker. And they'd like to know what DHSS is doing to inform people about misinformation.
It's a great question. Elizabeth, you want to take that on from a public information side?
Handling misinformation is a big task these days, and something that is very much, being discussed nationally and in Alaska as well. We do have a misinformation team that we're working with. And one of the things that we're doing is making some short videos. Like if we hear of a piece of misinformation out there that we think needs addressed, we're engaging with our experts from Doctors Inc. to all the members that you see on this hub team, and having them make a short recording and getting that out on social media. So, we also really need all of you to help with this effort as well. So, and it kind of goes real deep. I could talk a long time on this subject, but You know, another thing that needs to happen is working with our youth on media literacy and scientific literacy, and really having, you know, teaching everyone within our circle to be critical consumers of information and to really look at the source of where things are coming from, and to really kind of take a real deep look and pause and wait a minute before you pass any misinformation along. Thank you.
All right, thanks so much, Elizabeth. We have a few questions asking about additional measures that might be taken to, you know, help flatten the curve as we're seeing an increase in transmission rates. People are wanting to know, you know, what is the metric and threshold for additional action from a state level in terms of mandating masks or other sorts of measures? And, you know, what is the criteria for that, especially with hospitals at such overloaded capacity?
Yes, that's a great question. And there is the practice of public health, there's the science of public health, and there's the policy of public health. You know, public health can become political, but it should never become partisan. And in general, our team provides the same science and information to you all as we do to mayors who ask, city councils, governor, and whoever else. And then decisions to do things like mandates or requirements, or honestly protocols, are really up to those local school boards, those mayors, governor overall, on decisions that they end up making and being able to move forward along those spaces. So we provide the same information kind of regardless of where that's at. Different areas and different regions have different tools at their disposal to be able to move forward. I think that the word mandate it can be problematic in many ways, and I think that we all need to think about protocols that we can all do to be able to keep each other safe and healthy and well, be that a school or a business, and then ultimately it's up to each individual to be able to move those directions. So I would say it's very varied with different tribes, local regions, districts, all having different metrics. I don't know, Heidi, I don't know if Brian's on, anything else you would add along that, or?
Yeah, I mean, I think that people, you know, when they are asking for these additional tools, what we want to say is, what is the specific ask? What are you looking for? So we work really closely with the Hospital Association and the nursing homes and assisted living centers, and we're like, what is your need? And our job is to find that resource to plug into the need. And when it comes into the mandates, I would really concur with what Dr. Singh said. You know, we continue to meet at every level, just providing the education and really listening on sort of what their thought process is and what their concerns are and talking through those. And I think that that really alleviates a lot of the concerns, or addresses and kind of pinpoints and narrows down what the concern is. I would separate, you know, what are the needs, and those are the tools and the resources, which is what we're actively working on, with the messaging to the community. And that's going to take all of us sharing, you know, science-based information and really helping to share the correct information out in multiple levels. Is there anything else that anyone else wants to add to that? No?
I want to say, just because there's a rule doesn't mean people do it. And ultimately, whatever we can do to all have us do our part to slow the spread of this disease and this virus is going to be beneficial to all of us. So that continues to be incredibly important.
All right, let's see here. So we have a couple questions related to the data reported on the vaccine breakthrough report. Specifically, people are wondering why is the daily data left off in the download summary with the other data?
Louisa, I don't know if I don't fully understand that question. You don't either? Okay.
Okay, sure. So it sounds like we've got a couple questions here that are asking why the daily data is not included on the download summary with all of the other data. So specific to the vaccine breakthrough. Is there a reason why that is left out?
Yeah, so for vaccine breakthrough data, it would be amazing if there was like just this database, and when we got a positive in, it had all the correct information if they were vaccinated or not, we were able to move through it. But there's a lot of duplicate data. It has to be checked against if someone is vaccinated. people don't automatically end up in the hospital or not. Sometimes it takes a week or two to end up in the hospital. So some of that data can take a bit to be able to actually be displayed, and takes a lot of work on our data team to be able to figure out, was it a vaccine breakthrough and what that looks like. I really think that continuing to focus on trends is more important than any specific day. Like, that is the number one takeaway. So while we do these daily summaries, I mean, honestly, we've had a lot of debate of like, what's the purpose of them and should we even be doing them? Because people follow the day-to-day so much, and they can be somewhat inaccurate because, like I mentioned previously, it takes a while for the data to be reported in, or maybe there was a hiccup in one of the feeds and there were 500 cases that didn't come through immediately, and then the data team has to pull all that out and be able to look at the onset date, let alone vaccine and symptoms and all these other things that it's really important for people to know. So as a result, we really want to encourage people to look at our weekly summary that has kind of just the weekly trends, and then these monthly summaries of both vaccine breakthrough and hospitalizations, because we can have a much better picture of what's happening in that space when you look at a broader range than a single date. I see a lot of people on social media saying like, well, you said this day this and say that day that. Kind of think of it like the traffic. Like, if you're overall looking at patterns and trends, you'll see trends of like when there's more cars and not, but there might be a gap between a bunch of cars. And then just because like there was, something on the road and it slowed things down, and so it isn't all coming through. So I really caution people on looking at just the daily data to be able to overall see trends and look at that weekly or monthly. That's how I'm reading that question. Louisa, Joe?
Yeah, this is Joe McLaughlin. I'll just add to that. I really support what Dr. Zink just said at looking at trends, and that's the most important thing to do. I think the heart of this question is, hey, we want to know what's happening with vaccine breakthroughs, not only here in Alaska, but globally, what's happening nationally. I think there was a really very helpful MMWR that just came out looking at the trends. And so while we're talking about vaccine breakthrough, I'll just show you what the upshot of this article was. And the article is entitled, let me see if it doesn't let me go up, but it's an MMWR article that came out as a preprint on Friday. This figure shows the weekly trends in age standardized incidence of COVID-19 cases, hospitalizations, and deaths by vaccination status. So was a person fully vaccinated or were they not fully vaccinated? And looks at the rates. Here we've got May, June, July. So you can see this massive uptick in cases that we've seen nationally due to the Delta variant. We're also seeing an increase in vaccine breakthrough cases. But look, it's...
Hey, Joe, we can't really look. It just says blank. It just says you shared your screen. So,
oh,
yeah, we would love to look with you, but we just...
Oh, sorry. It looks like I'm frozen up. I'll try and get to it. Maybe I'll have to exit.
You can talk through it if you want, but we can't look.
No, it's way better to see the figures, so I'll try and dial back in. Oh, there we go. You guys have me now?
We have you, but we don't have a shared screen.
Okay, let me see if I can do this. I think it's really an important thing to show folks. So let me see if I can share my screen again. Okay, is that working now?
Now we got you.
Oh, good. Okay, so here's the figure. Here's the y-axis is age standardized incidence per 100,000 population. Here are cases, hospitalizations, and deaths. Blue is fully vaccinated. The black is not fully vaccinated. Here in the black, the not fully vaccinated, you can see this massive spike in cases that we're seeing nationally due to the Delta variant. We are also seeing a spike in cases in the fully vaccinated, but look, it's way different in terms of incidence. Much, much higher incidence in the not fully vaccinated group. Now, look at hospitalizations. We're also seeing a big uptick in hospitalizations in the not fully vaccinated group. Look what we're seeing for the fully vaccinated group. It's pretty flat. It's gone up just a small bit. This is really a strong argument for getting vaccinated. Here, deaths. We're also seeing a big uptick in deaths in the not fully vaccinated group. And look what we're seeing for the fully vaccinated group, maybe a small increase there. So this is about as convincing as modern medicine gets.
I guess I would just add, there's no reason to believe that we are fundamentally different as humans or the vaccine is different than what we're seeing in those things. So that's why it's important to look at those national trends. Louisa, anything else that you wanted to add on just like the reporting? No, okay. Just wanted to check.
All right, let's see here. So we have a few questions relating to monoclonal antibody treatment, the specifics around where to access it, what the timing should be after infection, and what treatment turnaround times are looking like. Dr. Cutchins, could you get us started with addressing some of those concerns?
Sure. So there's a kind of a clinical question in here about, what should an individual do? I think I'll kind of rephrase it and make it applicable to anybody who's considering monoclonals. So first of all, the question here, I'm glad your family member is vaccinated. Vaccine is our best tool. For anybody who's concerned about getting sick from COVID, the best way to reduce your risk is to get vaccinated. It is the most effective drug at preventing infection and reducing risk. It is really the only drug effective in preventing risk. Monoclonals are a unique drug class. They have to be given via injection or IV infusion. They're most effective if given early and really indicated for the people who are at most high risk for progression to severe disease. I think of them as like a safety net, not a guardrail. So in terms of questions like this, it's best to talk to your medical provider who has the complete history of your patient, to determine if you need monoclonals or not. That being said, earlier the better, and really they're only available for the first 10 days after symptom onset. The sicker you get, the less likely they are to work, to the point of, when you're in the ER about to be admitted, we're actually not even allowed to give them, because at that point, they're not going to help. So we have a couple other things. So we have updated our vaccine call line to be a vaccine and monoclonal call line. So that 646-3322 number. If you're having problems getting access to monoclonals, call that number. They know who's giving them in your community. That being said, most places, it's hard to go in. Some communities you can, most places it's hard to go in that day and get monoclonals. A lot of places it's taking sort of 1 to 2 days. So another thing to consider. I think I answered everything. I don't know if anyone has anything else to add to that.
I may add one thing. The monoclonals are also available for someone that has a significant exposure but may not yet be tested positive if they meet that risk criteria of being immunocompromised or immunodeficient. So it can also be done as a preventive, and that's been also authorized.
Then I would just clinically add, it's just impressive to see how many patients wait until they get really sick because they don't want to be a bother. They're like, I'm not going to worry about it. And then when they come in, either their 10-day window has closed or they're too sick for it to benefit. So again, this works best early on in the disease process. So if you're at high risk, please consider getting monoclonals early.
The last thing I guess I'll add to it is I'm hearing a lot of unfortunate reports of people taking other drugs that are not shown safe or effective, or nutritional supplements or vitamins or a lot of other things, hoping they'll get better. And most of them don't, because those drugs, none of those other therapies are really shown to be prevent COVID or to prevent you from getting sicker. So, monoclonals early are the one drug option that we really have, to lower your risk of acute infection. So I've heard a lot of unfortunate scenarios where people take these other regimens that are really complex and really unproven. They get worse, then they ask for monoclonals when they're ER, and it's too late. So that's kind of the other thing I really encourage people to talk to medical providers for.
And Dr. Cutchins and perhaps others as well, we have some questions asking about folks who aren't able to get vaccinated because of potential allergies or other underlying conditions. Could you perhaps flesh out the circumstances under which people wouldn't want to utilize vaccines, and how common is that? Are most people able to?
I would say Dr. Domain would probably be the best one to start with this one.
The true reason to not receive the vaccine is having a known allergy to a component of the vaccine. And it's important for us to note that risk is very low, very, very, very few, somewhere in the neighborhood of, maybe 3 to 5 per million. So if you have a known allergy to a component of the vaccine, then it would not be recommended. The good news is we have an alternate choice. There are sometimes we may feel one vaccine is preferred over the other. So then that's something you can talk with your healthcare provider about. So one is preference, and the other one is as far as which vaccine to get. But as far as a condition that you can't get a vaccine other than allergy, there really is not a condition that would warrant you to not get the vaccine. That is to the vaccine.
And the only thing I'll add to that is, fortunately, we have 3 different vaccines with 3 different components. Like if somebody truly does have an anaphylactic reaction to the polyethylene glycol in Pfizer Moderna, there's no polyethylene glycol in Johnson & Johnson. So, the good news with that is, we have different options, even to work around certain allergies.
All right, switching tracks a little bit to hospital capacity. Recently, Providence sent out a letter advising that they're no longer able to meet standards of care due to capacity. We have a couple questions here in the chat from folks who, let's see, hold on, it just disappeared. All right, so yes, a couple of folks are asking about that letter and expressing some concern about people being able to access adequate care. And they'd like to know, what is the state doing to support hospitals who are now at this critical capacity?
Yes, maybe I can start and we can kind of all chime in here in different avenues because there's a lot of different things from different areas where people are working. So first of all, as we've been saying on these echoes for some time now, and as you can see in our weekly summaries, we have kind of yellow, orange, and red for hospital capacity, and our hospital capacity has been in red, and then we have certain metrics for that, including the Anchorage Hospital is spending more than 90% of their time on diversion. So the hospitals have been incredibly full. I kind of feel like it's like the tide that's rising. And initially there's rocks that you can jump on, but as more and more cases climb, there's less and less places to be able to go to. And we're starting to get to the point that there is just no more place for people to transfer to and no more beds for people to admit to. So they're boarding in the emergency department, they're holding there. People are having to care for sicker patients in remote and rural locations than they've ever had to care for before. We've had increasing challenges accessing particularly things like dialysis. So people may need regular dialysis in the outpatient setting, but also when people get really sick, they may need dialysis because their kidneys suddenly fail. And that's a very limited and special type of care that is only provided at a few of our hospitals in Alaska. And so the services are increasingly becoming limited. Unfortunately, this is also happening as the lower 48 has also been surging. And so the ability to transfer to Seattle, to Washington has been increasingly limited. We were on with the hospitals this morning, and one example was, the clinician spent 9 hours trying to find a bed for a specific patient. Matsu Regional has 14 beds for their ICU. They're caring for 20 ICU patients. So just like their expansion into other areas to try to care for the patients that are there. Every hospital then tries to deal with that surge differently. And then as a state, we try to support them to kind of load level and to provide additional resources. The best thing we can do is not have so many people going to the hospital sick. So we want to make sure we're there for you to be able to care for you if you need care. And I saw a comment in the chat box of someone whose dad is on day 8 and is quite sick. I would highly encourage them to be seen because oxygen can make a big difference in this case. So please get seen if you're very sick. That being said, it may take longer to be seen and we may not always be able to transfer people. And the more that we can collectively do to decrease those cases, it will just make the available hospital beds to be there overall. Hospitals have their own surge capacity plans. They have their own disaster plans, and they also have their own crisis of standard plans. And that's what we saw specifically come out from the medical executive board yesterday from Providence Hospital System. And so that was their ability. They've been unable to continue to surge, and they're having to figure out how to take care of patients slightly differently because of the lack of care, and then sometimes very differently because of just the lack of staffed beds and the staffing resources that they have available. From a state perspective, we're trying to do lots to help on that. So 1, encouraging us all to do what we can to minimize the number of COVID cases. 2, we have a daily huddle with all of the hospitals to understand how many people they're boarding, what do they need, what are the resources, and how can we support them in that space. That has meant getting oxygen to certain hospitals. That's been deploying nurses and additional staff to different hospitals if we're able to have it, helping to work with transfers so they don't have to actually do the transfer themselves and trying to work in that space. We have been also applying for these GSA contracts to try to get additional nurses, respiratory therapists, and staff in the state to be able to help out in that surge capacity. We've been working with Medicaid. We've been working with private insurance to do what's called lateral transfers to be able to send people back to another region. So maybe someone comes into Anchorage, gets stabilized, but then their care could be done maybe back in Bethel after they've been stabilized, and they don't need the subspecialty care that's in Anchorage. So being able to do a lateral transfer back. So there is a ton of work in the patient movement sector that's happening. And we do have a crisis care committee that's met and really discussed kind of where we at as a state. Ultimately, there's just not a lot of resources. There's not a lot of ways to move this direction. And there are very invested clinicians trying to make the best decisions that they can. And we continue to meet with them and be able to pivot in as many ways as we possibly can to support hospitals where they're at. But ultimately, we all need to support hospitals. We all need to consider getting vaccinated. Get vaccinated if you haven't. Wear a mask when you're in indoor spaces. Keep our circle small, because that is the single best way we can help hospitals. Dr. Rabinowitz, I know that you're kind of an active clinician. I don't see Heidi or Jean on this call. They are kind of doing additional space, and maybe Brian, other thoughts?
I think you covered most of it there. I think what we're seeing on these daily calls that we're having, and the things that you all are seeing in the media, it's really not a space issue so much. It's more an equipment and a staffing issue. So we're really focused on that. Like Dr. Zink said, we're working to, hopefully we'll be successful with contracting with some outside staffing companies to get that additional staffing up here. We've been working very closely with the Alaska State Hospital and Nursing Home Association. And Heidi mentioned this earlier when she was on, to identify the real need, what types of clinicians are needed to help with this situation we're in right now with the surge that's going on. So we're hopeful that we're going to be able to bring up folks from these contracting agencies in the lower 48. We're kind of all hands on deck to support expediting the background checks and the licensing things. That's a difficult situation, but I think we're prepared to do that if that comes to fruition. We're able to bring up some temporary staffing to address the surge. So I think you covered everything else, Dr. Zink.
And we've looked, I see other comments like Samaritan's Purse, military, boats, ships, like we have looked in all of those different nooks and crannies and avenues that we possibly can between Hurricane Ida, between the surges in the lower 48, Samaritan's Purse is currently set up in Mississippi, the earthquake in Haiti. There's just a lot of demand right now. And so we have been looking for and putting in requests everywhere we possibly can to support our hospitals better. But there just aren't many ways to action those asks at this time. So I wish I had better news, but I am constantly impressed at Alaska healthcare providers and hospital teams trying to problem solve really challenging situations on a day-by-day basis. Anyone else on that topic?
All right, just a few more questions related to hospitalizations and capacity. Dr. Zink, others, do we anticipate that other hospitals will move forward like Providence did recently and implement crisis standards of care?
It's very much an internal decision. I mean, I would say that they're almost all, not all, but almost all at some crisis level right now. They are caring for patients in places that they don't typically care for patients, changing their nursing to staffing ratio. So instead of one nurse caring for 2 ICU patients, they might be caring for 3 or 4 ICU patients. They might be discharging earlier than they normally would. There may be longer lengths of stay. So the vast majority of our hospitals are in this situation right now. Some have crisis standard of care kind of committees that are, have been set up and are already set up, and they kind of activate that. Other ones don't, and they just make the best decisions they can, kind of as a smaller unit and team. Some states have crisis standards of care in their statute. We don't. Ours, we do have kind of a crisis standards of care document that had been kind of ratified last year. It's still in existence. It doesn't really address staffing shortages super well. It's much better for like, what if you don't have enough vents? Like, how do you figure out things like that? So the practice of medicine is much more of an art than a science. And so I think it's very diverse. And particularly when you have a small hospital that's just trying to do their best on a day-by-day basis, you're going to see changes from a big surge to really being able to slow things down quickly, versus Providence is just a much bigger system. They have an ethicist on board. They have a crisis standards of care committee. So I think it's going to depend a little bit more on size, but that doesn't mean that not almost every one of our hospitals is facing the same challenges that Providence is facing right now.
All right, thank you so much. So let's see, we have a few questions related to testing. Dr. Cutchins, would you mind fleshing out the difference for folks between PCR tests and TMA tests? And then we'll move on from there and some additional questions about access. And
all right, I'll tell you what, I'll turn it over to Dr. Parker to talk about PCA versus TMA and cycle thresholds, and then I'll cover rapid testing and kind of the access questions.
Sure, no problem. Okay, so let's talk PCR. So that stands for polymerase chain reaction. This is an assay that targets nucleic acid, so the exact sequence of the coronavirus. It uses temperature changes to amplify that to a level that we can see it. And so you sometimes think about these as how many cycles is it going to take before we can actually identify that it's there. And so sometimes cycle thresholds will come in very low, meaning that you've had a lot of virus in that sample. Sometimes those cycle thresholds will be higher, like in the 30s, and that will indicate that that person had less virus in that particular sample. TMA stands for transcription mediated amplification. It uses a little bit of a different process. It uses more of a RNA transcription process. It is also targeting the nucleic acid, so very similar to PCR. What we're seeing with TMA is that it can be much more sensitive than some of the PCR assays out there, but we are actually trying to validate a PCR assay here at the State Public Health Labs that is very comparable. So, you know, PCR and TMA, they both target the nucleic acid. One of the pros for TMA is it doesn't require as much labor, so you don't need as many people there to handle that testing. I think in Alaska, we're really utilizing both PCR and TMA so that we can get the capacity of testing that we need. Does that answer all those questions, Coleman?
Yeah, and I'll add both TMA and PCR are molecular tests. They're both high complexity tests done at a lab, so they both fulfill those requirements.
Right.
There's a couple questions in here about rapid. So rapid, the biggest limitation on rapid testing is their low volume. I always like to think the rapid molecular test is like a Keurig 1-cup coffee maker. You know, if you have one person right there, you do one sample at a time, but you know, if you have 30, the last person takes a really long time to get results. It's very, very labor intensive and very difficult to test a large number of people on rapid. So that's why if you look through the whole pandemic, our large urban areas have had very little access to rapid testing. That's why like places in the airport, like you just couldn't have enough people and testing devices to test everyone on rapid. I will say at most of our airports, you know, turnaround time is like 24 to 48 hours. You know, my wife got deployed the other week, and even though she's vaccinated, had to get tested to where she was being deployed to. I mean, she had results in like 24 hours, almost exactly, from the Anchorage airport. So we are seeing pretty quick turnaround times, even at our drive-throughs with longer lines. You know, we're really maintaining quicker turnarounds. The other thing I'll add about cycle thresholds is you can't compare cycle thresholds from one device to another. So imagine like if you had a Ford and a Chevy and you couldn't compare miles per gallon, like cycle thresholds are the same way. So like one device, if the cycle threshold's 24 and on another device it's 23, like you don't know what the difference in those meanings are. Also, there's a lot of things that can lead to higher cycle thresholds. You know, inadequate samples, maybe that sample sat for long, maybe it took longer to transmit. So we can't really correlate cycle thresholds to how much virus was in the person. It's how much virus was in the sample.
all right, and so folks are also wanting to know if the incubation period for Delta is different. Should they be waiting longer, or should they no longer wait to test? I'm sorry, one second. They're asking, should we no longer wait to test for 3 to 5 days after exposure? Yeah, what is the present recommendation? Thank you.
Yeah, this is Joe McLaughlin. I can start with that. So the incubation period for Delta does appear to be shorter, probably about 24 hours shorter, maybe as much as 48 hours shorter, but somewhere in that range. CDC is still recommending that if you're fully vaccinated and you come into close contact with a confirmed case, that you go ahead and just mask up and then get tested 3 to 5 days after your exposure. I would err on the side of going closer to that 5 days actually, but that is still the recommendation, testing 3 to 5 days after that exposure.
All right, excellent. Thanks so much. And what is the state testing guidance for positive home tests? Is lab confirmation still recommended?
So with these home tests, we do recommend that, speak to your healthcare provider if you test positive or you test negative. I will say most of the home tests have extremely good performance in the positives. If you are a positive on a home test, there is like a 98, 99+% chance that you are positive. The biggest disadvantage of some of the home tests is you get a lot more false negatives. So that's when somebody is in fact has the virus and tests negative. But if any of you test positive on a home test, I would count that as a positive, especially with how much COVID we have circulating, and reach out to your medical provider to ask what you should do next.
All right. And let's see, Dr. Demain, we had a participant who was asking about travel. They recently had a baby and are interested in visiting family that they haven't seen for a very long time, an unfortunate reality during the last couple of years for many, and I know. And they'd like to know what the level of risk is, especially if they're breastfeeding and have been vaccinated.
Yeah, in that case, I read the question as well. This is a woman who did fortunately receive the vaccine during pregnancy. So those antibodies that she made in response to the vaccine do indeed cross to the baby. So the baby does have protection in that regard. When she's breastfeeding, those IgG antibodies that are protective also cross in the breast milk. So at 2 months, the baby is continuing to enjoy the protection from the mother's antibodies. Those antibodies are going to be protective probably for the first 6 months of life. After that, your baby will start making their own antibodies, but unfortunately, without exposure to COVID and or vaccine, will no longer have the benefit of the maternal protection. There may be some continued protection through breast milk, but we don't really know how protective that'll be. The major protection is going to be what was with the antibodies that the baby received during pregnancy. So to finish for travel, you and your baby certainly do have a degree of protection. As we know, there are some vaccine breakthroughs with Delta, so continue to mask. And obviously you're not going to mask your baby, but just be cautious with contacts because both are vulnerable. But the good news is those that are vaccinated have a much less chance, 10 times less chance of severe illness requiring hospitalization.
And so for folks who are vaccinated and might be traveling with unvaccinated folks, could you speak a little bit to the risk in that circumstance, and how vulnerable would the vaccinated person or unvaccinated person potentially be?
Well, the risk of a vaccinated individual becoming infected is about 5 times less than one that's unvaccinated. So if they're traveling with a partner, for example, that is unvaccinated, that unvaccinated individual is going to be at greater risk. And if they're living with or traveling with that unvaccinated person and become exposed, then there is certainly that risk of them becoming infected. So it's hard to really put a pure number on that. Joe might be able to do a little better job. But again, the fact that they're vaccinated, that's going to offer the most protection along with using masks and being cautious with social distancing.
I think you answered that very well. Thank you, Dr. Demain.
All right. A few questions here related to who is eligible for the third dose? What constitutes being immunocompromised? And separately, what is the word on boosters?
Kelsey.
Actually, I will toss it to Dr. Rabinowitz to talk about the third doses and boosters first to get that clarification.
Perfect. So this is a great thing to clarify because there is a lot of confusion about third or additional dose for immunocompromised, which are currently authorized. And that is very different from boosters, which haven't been authorized at this point. So additional or third dose for immunocompromised individuals are due to studies and data that we've seen where if you are moderately to severely immunocompromised, when you get that initial 2-dose series, you might not get as much protection as someone who is not immunocompromised. So the studies show that having a third dose for those individuals significantly increased their protection. And so for the additional or third dose, this is for moderate to severely immunocompromised, they can get that third dose 28 days after their second dose if they're eligible. We can put a link in the chat for some of the immunocompromised situations that this entails, but it is not an exhaustive list. We encourage you to speak with your healthcare provider if you have any questions about whether or not you qualify for that. We really want to encourage individuals that are immunocompromised to please go get your third dose, especially with this Delta variant. We are seeing significant improvement in protection after that third dose. So that is very different than booster doses. The White House has talked about initiating booster doses possibly as soon as September 20th. They are currently looking at this data, and the FDA actually has a meeting on Friday to continue looking at booster doses and kind of what that means. We as a state have a booster response team and are mobilizing many work groups across the state and with our partners getting ready for boosters and planning around different scenarios depending on what is authorized ultimately by the CDC after that data is reviewed. So we will continue to update on boosters and kind of the details surrounding that. Thank you.
Kelsey, is there anything that you wanted to add?
So I did throw a link in the chat of the CDC's webpage that really outlines the immunocompromised and that additional dose. And, as Dr. Rabinowitz mentioned, that list is not exhaustive. So I think it's a good starting point, but just, that if you don't fall within that list, that doesn't necessarily mean you are not eligible. So to really speak with your provider. And then just one thing I will say, I know that all over the media, there has been this September 20th, circling of date that this is our date for boosters, September 20th. And I just want to be really clear that this is our planning assumption, that really it was the week of September 20th that we were given as this really time frame to be prepared for boosters. And as Dr. Rabinowitz mentioned, we are planning and we are working with all of our providers and partners to try to make sure that we have things up and running. But I would just caution folks to really keep that date circled because that was really this planning target. And we'll see, as we have a meeting scheduled for Friday, and then we'll see if something emergency happens over the weekend. But at this point, we just don't know that is really a planning assumption at this point.
And so I would just add to that really quickly that in terms of the chat, I did see a few comments about immunocompromised and not presenting any documentation. And the reason is they're not required to present any documentation. So all they have to do is self-attest to being immunocompromised. And the goal is not to put up barriers towards vaccination.
All right, we did have a couple additional questions asking a little bit about what constitutes close contact, both for vaccinated folks and unvaccinated folks. Can we go over, some of those criteria and also perhaps some resources for folks to refer back to later?
Sure, anyone, go for it. Joe, Louisa?
Sure, Louisa, do you want to take that one or would you like me to?
You can take it. I mean, I think the bottom line is nothing has changed.
Yeah. Yeah, so 6 feet, 15 minutes, close contact for most situations. If you're talking about school kids in a school setting, if both kids are masked, then it's the 3-foot rule for 15 minutes. So if they're within 3 feet of each other, as long as they're both masked consistently, then that would be the threshold for what we consider to be close contact.
And then again, if you're vaccinated, even if you're a close contact, you can continue to go about your world. However, recommend wearing a mask and getting tested 3 to 5 days afterwards and watching for symptoms for 14 days. So being vaccinated keeps you in the workforce and in the game much more easily. So another good reason to get vaccinated.
All right. And Dr. Cutchins, I know that we had some questions asking about some vaccine terminology. Want to cover some of that?
Sure. So today we were talking about like concentrate, suspension, microdiluent, and suspension. So I'll use the orange juice analogy. So if we take orange juice with pulp, that is a suspension. You know, the solid stuff settles out. If we shake it up, it stays in there and it suspends up. So we're specifically talking about vaccine. The concentrate is like the mRNA inside the bubble. The concentrate is the active ingredient. The micro suspension is the mRNA surrounded by the little lipid particle. The microdiluent is the stuff it floats around in. So like when we look at Pfizer, that's essentially water with sodium chloride, potassium, phosphate, and some sucrose in it. And then the suspension is the whole product.
All right, excellent. Thank you so much. So let's talk a little bit about flu. You know, when can we expect some of those shots coming in?
Matt?
Hi, I am happy to take that as I divert my phone. Flu vaccine is available now. State supplied vaccine is available to be ordered. If you're interested in receiving state supplied vaccine, there are 2 programs that you can enroll in. One's the Vaccines for Children program, and the other is the Alaska Vaccine Assessment Program. In terms of flu, you should get the shot before the end of October. And there are a lot of recommendations and guidelines, and I'll put those in the chat.
Excellent. Dr. McLaughlin, did you have something to add as well?
Sure, I'll just add that, you know, we really want to encourage people to get their flu vaccine this year. Ideally, I think as Matt said, we want folks to get it by the end of October. And the reason for that is because we don't know when the flu season is actually going to start. It's pretty variable from year to year. Typically it peaks, you know, February-ish, January, February, March. Well, probably January, February, but not always. Sometimes it'll peak as early as October. But oftentimes it's sort of that December, January, February time is when we see the biggest peaks from year to year. So just really want to encourage folks to get vaccinated. Remember that children who have not been vaccinated previously, and Matt, you can kind of go through the age range. I think it's 2 to 8 years old. Is that right? They need to get 2 doses of the vaccine. And so we really recommend getting started now for those kids. And I don't know, Matt or Lisa, if you want to say more about that.
Yeah, so as Joe mentioned, in terms of children, you want to get them vaccinated sooner rather than later because they need 2 doses. So those are those individuals. And then also pregnant women in their 3rd trimester of pregnancy. This is a new recommendation. It's recommended to get vaccinated with the flu vaccine as soon as it's available.
And just one quick clarification, it's for kids if it's their first flu season of getting vaccinated, that they need to get 2 doses. Every year after that, it is just the 1 dose. So it's really just for those kiddos for that first year. And flu is available. I know Matt mentioned that from the stock that is supplied by the state, the public stock, that is available to order, but there is private vaccine out there. So pharmacies, they are vaccinating already. And so, reach out to your provider if you want to get vaccinated at your provider's office or at a pharmacy. There is flu vaccine available, so we encourage you to do so.
All right, so
I'm sorry, Erin, just want to make the correction. So in terms of the children who are eligible for the 2 doses or are recommended to get the 2 doses, it's children aged 6 months through 8 years if it's their first flu season.
all right, and I see that Matt did provide an outline of some recommendations here in the chat for folks to refer back to as well. All right, so we are nearing the close of our session. I am aware that we've had a lot of questions today, many of which we could not get answered, but I am happy to compile those for our hub team, especially the ones related to specifics around data and reporting, and perhaps those can get integrated into our next session next week. Any additional updates or comments from our hub team before we close?
Yeah, I was just going to add, for the data, thank you for grabbing those, Erin, and we'll try to include them in next week. I see a lot of questions in the chat box about like individual, if I've got this condition or that condition, do I meet criteria for a third shot? I'd really encourage you to take a look at those guidance and talk to your primary care doctor about that, because we can't give medical direction here. And oftentimes people's history is a little bit more complex than a Facebook comment on here. So highly consider doing that. I also see comments in the chat box about people who are sick and not feeling well and not sure what to do. Again, people's oxygen level can drop really low with COVID-19, so encourage people to get tested. The other thing I would say is that, we do have false negatives with the testing. So if you are sick and you test negative, be it a home test or another test, still please stay away from others, because you may still have COVID or you may have something else like the flu or RSV that's highly contagious and making other people sick. And so really we shouldn't be hanging out with others while we're not feeling well, particularly when our hospital capacity is so strained. And consider getting a repeat test if your symptoms are lingering and you're still not feeling well. Again, we do see false positives and sometimes an additional test can be useful in that space. And the last thing I'll say is there's a lot of questions about, crisis care and capacity and, kind of winging it, or what does this look like? Medicine is incredibly complex. I remember I had this patient who once asked me for the checkbox of things we would do to their patient. And the reality is their heart rhythm kept changing as I was having that conversation with them. And so it can be really hard to say, if we do this, then we do this. The system and the body, all of our organs interact with each other, and it can be a very complex process. So we continue to support hospitals as they're on real time making real life decisions, really with the promotion of the health and well-being of all Alaskans, regardless of their vaccine status, their age, their underlying medical conditions. But it is just challenged and limited in this time. And as a result, it's not a clear checkbox to follow through along, but we'll continue to support hospitals and clinicians as they're doing their best to serve you all. And we can all serve each other by slowing the spread of COVID. So just a few other comments based on what I'm reading in the chat box. Thanks.
All right, thank you so much, Dr. Zink. Any other members from our hub team? All right, well, thank you so much to our participants again for your, taking the time out of your days to join us and ask these really important questions. I know a lot of you have shared really personal stories and experiences, and I know that it's a difficult time for many of us. So thank you again for your time and participation. Just a reminder that our next session in this series will be Wednesday, September 22nd from 12 to 1, and you can visit the shared box folder to access videos and resources from all that goes in our public health project, along with this one. And we look forward to seeing you next week. And in the meantime, take care of yourselves and each other.